I'm Ian Russell. I was a consultant anaesthetist since 1981 until 2013 at Hull Royal Infirmary, so I've now been retired for a little over 4 years. Anything else you want to know?
That's fine to start with. Yes, I'm Professor Mike Wang, Emeritus Professor of Clinical Psychology at the University of Leicester, United Kingdom. Okay, so the first question is, why do so few anaesthetists use the isolated forearm technique in their clinical practice?
I think that's a question that has quite a complicated answer. In the early days, there was a lot of misinformation about the isolated forearm technique, with quite influential people saying in simple terms it didn't work for one reason or another. And these particular reasons were all totally false, presumably from a lack of proper understanding of the isolated forearm technique. So a whole generation of anaesthetists have grown up during their anaesthetic career believing the isolated forearm technique didn't work, because that's what they've read in reviews of depth of anaesthesia, in anaesthetic textbooks, and they've never really taken it any further than that. So I think that's one reason. Now that the isolated forearm technique is sort of starting to enter mainstream literature, we're now seeing the younger anaesthetists saying, well, I can't use it because I haven't been trained to use it, and there's a protocol for this, there's a protocol for that, and I have to have a certificate of what's the word? Competency before I can do anything, and I don't have a certificate of competency, and there isn't anyone who can teach them how to use the isolated forearm technique so they can get a certificate of competency. So you've really got these two things that are going on. And then I think there's also just a great inertia, because people think, oh, it's such a faff putting on an extra tourniquet and doing this and doing that. But in reality, if you have your anaesthetic team, your ODA or anaesthetic nurse all geared up, it's all done and dusted in no time at all. So it's not really a big problem.
What do you make of J.D. Pandit's recent admission that despite the fact that a recommendation from NAP5 was that the isolated forearm should be part of the curriculum for trainee anaesthetists, and yet that particular recommendation never made it through, was never properly approved by the Royal College?
I don't quite know what to make of that, because I hadn't actually heard that until earlier today. But perhaps from the response of the college and the association in the past to things where you and I have been interviewed or been something written in the paper, it's perhaps not surprising. But I don't really understand what's really behind it, because I mean the isolated forearm technique is such a simple technique.
Sure.
And it's so reliable as well.
Yeah. But is that the problem? I mean, is it the fact that many anaesthetists like technology?
Oh yes, I think
and they don't like talking to patients.
Well, I think that's probably very true, because that's when I took up anaesthetics. I quite liked technology, and I was very poor with my patient communication skills, and anaesthesia to me seemed to be the ideal thing where, well, at that time your patients were asleep, and it's really only with experience that I've become much more relaxed and relatively good with patient communication.
So if somehow the isolated forearm was a black box, it might actually be more acceptable.
Yeah, I'm sure it would be if it was a black box.
And especially if it didn't involve trying to communicate with patients.
Possibly, yeah.
Okay, thanks. So, how would you argue that more anaesthetists should be using the isolated forearm technique?
Well, I think it's probably very hard to get them to just start using the isolated forearm technique with all the things I've already said. But there are ways of introducing yourself to it. I'm sure most anaesthetists will have experienced a scrub nurse or the surgeon saying, "Oh, the patient's moving her left foot." To me, that is the ideal opportunity for speaking to the patient. You know they can move their left foot, and you ask them to move their left foot, and then you can be sure whether this is just a reflex because the surgeons are doing something that's causing the foot to move, or whether in fact the left foot is the only thing the patient can move, and that's what they're doing. Which takes me back to my time as a senior trainee in Aberdeen, when I was in charge of the emergency on-call anaesthetists, and one afternoon I walked into an operating theatre just to see how the trainee was doing with a particular laparotomy. Just as the scrub nurse said, "Patient's moving her left foot." And I said to the anaesthetist, "What are you going to do?" And he picked up a syringe of, I think it was pancuronium, and said he was going to give some more muscle relaxant. And I said, "Are you going to do anything else first?" And he looked very bemused and didn't really seem to know what. So I actually spoke to the patient, and using a Christian name, I just said, "Francis, can you just waggle your left foot for me?" And she did. And I then said to the anaesthetist, "What are you going to do?" And he said, "Well, I'm going to give some pancuronium." I said, "But the patient's awake. Francis, can you just waggle your left foot for me, please?" Waggle, waggle. "What are you going to do?" "Give some pancuronium." "But the patient's awake." And he said, "No," he said, "the patient cannot be awake. I am giving an anaesthetic." To which I said, "No, I think you only think you are giving an anaesthetic." And so we deepened the anaesthesia, and a few minutes later the responses stopped without any muscle relaxant. So I think this is an important thing. The patient moves some part of their anatomy, they wiggle their eyebrows or whatever. Ask them to do that, and then you have an insight into it. And this is a very useful introduction for actually using the isolated forearm technique. And then, of course, if you do happen to come across a patient who's been awake during a previous operation, these patients are often extremely anxious or worried about their anaesthetic. And if the anaesthetic doesn't involve muscle relaxants that you're about to do, well, that's fine. You can reassure them very quickly about the issues of muscle relaxants and awareness. But if it's a more major thing where they will need muscle relaxants to be given, you can explain the isolated forearm technique with them. And I must have done that probably into double figures now. And the patients really, really understand it very quickly. They seem to understand it much quicker than many anaesthetists understand it when I try to explain the technique to them. And and that actually relieves them. Rather than being worried, they are very relieved. And it's interesting that when I've been lecturing, many of the delegates will come in and say, "Well, how do you get patients to go in your trial when you tell them they're going to be awake during their operation?" I said, "No," I said, "you have the wrong end of the stick. They are not intended to be awake during the operation. I tell them there's a possibility they will be awake, that I am doing this anaesthetic using a particular monitoring technique which is supposed to tell me if you are conscious or unconscious, but this is my backup, and if you happen to wake up, you can tell me you're awake." And they are very glad. They are more than happy to come into the research project, knowing they're going to have this drug that will paralyze them, but they actually do still have a means of communicating with me.
And the fact that you'll then be able to deepen the...
And I can deepen the anaesthetic. Usually what I say is you'll be able to say, "Hello, can I have some more anaesthetic?" And and they are more than happy to go and make in the trial.
Just going back to the earlier anecdote that you were saying about the trainee anaesthetist and the pancuronium, when you said to him, well, the patient's awake, and he said to you, no, the patient can't possibly be awake, I'm giving an anaesthetic. Doesn't that say an awful lot about the mindset of a junior anaesthetist like him?
Well, I think yes, it certainly did at that time.
Yeah.
They believed that they're giving an anaesthetic so the patient is asleep. For some cesarean sections, I will use a isolated forearm technique routinely. We don't give very many general anaesthetics, but if one comes along, I will try and use that as a teaching experience. And I have had several occasions where experienced registrars were giving the anaesthetic. I was looking after the isolated forearm technique, and during intubation, the patient's hand suddenly rises up. I grab hold of it and speak to the patient, and she squeezes my finger, and the registrar just looks absolutely dumbfounded. He basically doesn't know what to do.
Yeah, absolutely.
Because they just assume that patients are unconscious when they intubate them.
Yeah. But for me, it's kind of like this sort of black and white mindset that once a patient is on the table and the anaesthetist has given an induction, they're then this piece of meat, and they're no longer human. And then you come along and actually demonstrate that actually this is a human being who's capable of communication. And that really upsets the apple cart.
I think from that point of view, things have maybe even got worse over the last 15, 20 years, because we have more and more sophisticated monitoring, and we're to a certain extent moving further and further away from actually having hands-on patients, whereas once upon a time you might be feeling the pulse or the temporal pulse, or feeling for sweat, or looking in the eyebrow, or you see very little of that going on these days, because the anaesthetist sits there looking at the monitor all the time and doesn't have that same patient interaction anymore.
Sure. Right. I was going to ask you a question about the FDA in America, bearing in mind that this will be an international website on which the video will be uploaded. But actually, I asked this question of, gosh, I've forgotten who it was. Who was it? Someone yesterday, an American.
About the FDA?
Was it Bob?
Yes.
So I was talking to Bob about the isolated forearm.
Bob Vazelis.
And the FDA, and he made a very good point, which was actually, as far as he's concerned, no FDA approval is required, because
tourniquet
is already approved, and a blood pressure cuff's already approved, and it doesn't involve any equipment that isn't already approved by the FDA. So as far as he's aware, there is absolutely no reason why the American anesthesiologists shouldn't use the isolated forearm technique. Although I have actually had a conversation, I remember it very well, I think I was having dinner with two very eminent and very well-known American anesthesiologists, and I mentioned the isolated forearm technique, and they said, there's no way you'll be able to use that in this country, because it'll never get FDA approval, and you'd have to do thousands of tourniquets and demonstrate no tissue damage or nerve damage as a result of using the isolated forearm technique. But as I suspected, it's just an excuse.
Yes, I think it's just another excuse. I mean, the tourniquets have been around for years and years and years, and the side effects and the problems of tourniquets are well known. And for the IFT, they're only up for 20 or 30 minutes, not the sort of 2 hours that orthopedic or plastic operations might be having.
So, in your own clinical practice, I think you've already answered this question, but I'll ask it anyway. In your own clinical practices, how do you interpret spontaneous movements when you're not using a muscle relaxant?
I mean, usually spontaneous movements are reflex movements. That's the most likely reason, but I always take the opportunity to establish, just in case it's not, what the state of the patient's mind is. Do they actually respond to commands? whether they respond to commands or not, the treatment's the same. You just deepen the anaesthetic a little bit.
Yeah.
And I very rarely would give any more relaxant just
Yeah.
like that. It's usually deepen the anaesthetic.
Yeah. Something else that's been coming across in these interviews is that, and this is variable depending on the country, but there is a concern about communicating directly with the patient in terms of what the surgeons and other theatre staff will make of the anaesthetist doing that.
Yeah.
In a sense that they're worried that this will undermine the credibility of the anaesthetist. I mean, are they competent if they're having to interrogate the patient about whether or not they're conscious? You clearly have absolutely no problem at all with this.
None at all. No.
I wonder if you have any sympathy for some of your more junior colleagues with maybe a very senior surgeon.
Yeah, I mean, it would be difficult for the junior anaesthetist and the more senior surgeon, but overall it comes down to educating surgeons as well.
Yeah.
And you know, this takes me right back to the very first isolated forearm patient I saw with Mike Tunstall. I was actually giving the anaesthetic, succinylcholine, thiopentone, succinylcholium, intubation. Mike was fiddling around with his timing clocks and things and making sure that the isolated forearm cuff was ready to blow up as soon as the succinylcholium wore off, because we didn't actually use it during the intubation period at that time. And the obstetrician is standing down at the bottom end of the patient, and he said, I'm just going to put this wee tube in your bladder. Is that okay, Mrs. Can't remember the patient's name. And the patient went. I was absolutely astounded.
Yes.
And Mike quickly grabbed hold of her hand, because clearly the succinylcholium wore off, and so she was awake and responding to it. He just carried on with his usual thing and said, you'll be drifting off to sleep in just a moment, because I think she was on 50-50 nitrous oxide and probably about 0.2 or 3% halothane. And sure enough, she just, over the next couple of minutes, she just stopped responding, and then we started surgery.
Sure, right. Okay. We've obviously had our conversations with J.D. Pandit, and I want to ask you, do you think there's such a state as dysanesthesia or unconnected consciousness, if we talk to Jamie Slay? And is this an acceptable state for surgery?
I find it very difficult to actually understand that particular concept, and in all the reading the literature and even in a debate with J.D., I get the impression that the concept is actually built mostly on the results that you and I have published. But that is very difficult from the normal situation, very different from the normal situation, because in these research patients, the command is coming every minute or every 2 minutes, so the patient has very little time to do anything on their own. And all I can say is that in those cases where my patients have not been in a formal trial, but I still use an isolated forearm technique with them, very often patient movement is the actual thing that stimulates you. I will see the arm starting to rise up off the arm board, and then I will go and take hold of the arm and speak to the patient and get a response straight away. So they don't lie there and not move if you're not actually giving them the commands. I suspect by giving them the commands so frequently, they know you're in contact with them. They are reassured. And if they're not in pain, they have no reason to move, just the same as they have no reason to move if you're using a spinal or an epidural anesthetic. They don't wave their hand around and try and climb off the table all the time under epidural or spinal. So why should they, with a general anesthetic, when they're awake, because they're relatively heavily sedated at the time and they're comfortable, so they just lie quite quietly. And I don't think it's a reasonable state to carry on surgery, because we really don't know exactly what's going on in their mind at the time and how that's going to affect things sometime in the future, even if they have no conscious recall.
Yeah. So,
And this- I mean, there may be no particular problems where they're comfortable, but in the middle of surgery, the stimulation is very, very variable, and they may be comfortable one moment, but they may be actually in extreme pain just 90 seconds later or something like that.
Sure.
And we just don't know what effects that's going to have in the future.
Sure. Yeah, absolutely. So I've talked about implicit emotional memory and the possibility of trauma, indeed, that sometimes maybe patients are distressed, possibly in pain, intraoperatively. Of course, the other bit of evidence against JD is the Breckenridge, the infamous Breckenridge and Aikenhead
Oh yes.
example,
Yes,
where the patients were actually trying to remove
the surgeon from the operating theatre.
Yeah.
And the treatment for it, rather than deepening the anaesthetic, was to release the tourniquet and paralyse the arm.
Yeah, absolutely.
Because the blood pressure and pulse rate and all the rest of it were normal.
Yeah.
Yes.
Meaning, rather like your inexperienced trainee wanting to reach the pancreonium, even very experienced anaesthetists like Breckenridge and Aikenhead still believed that the patient was anaesthetised.
Yes. And that these were just purely reflex movements.
Yeah.
They may have been purely reflex movements, but we don't know because no one spoke to the patient.
No, exactly. Okay. In your paper, Midazolam, Alfentanil and anaesthetic, many of your patients indicated consciousness and pain and yet had no post-operative explicit memory. Is amnesia an appropriate endpoint for general anaesthesia, and why not?
I think this goes back to what we've talked about previously, that we really don't know what's happening or what will happen in terms of these memories. I mean, there are two aspects to it. One, the patient is actually in pain and experiencing pain at that time. And even if they don't have any recall for that, they shouldn't really be experiencing pain because that, at that time, is a real experience for them.
Yeah. So there's the ethical argument.
There's the ethical side of it. And then again, we really don't know what is going to happen in the future. Is this memory suddenly going to just pop out of the ether sometime with some triggering thing in the future, possibly another anaesthetic?
Sort of breakthrough post-traumatic stress disorder or something of that kind.
Yeah.
Anthony, those were my main questions.
I have a series of questions.
Yeah.
So,
do you want to come and sit here?
No, I'll just do it from what scope that it works. I've done it before. So one of our experts said that in the literature he found 46 cases of isolated forearm technique which represented a sample size of 1,500 patients, and that there were no spontaneous movements of the patients under the isolated forearm technique, and he felt that meant it wasn't that the patients, you didn't really need it, or not. You've heard this analysis before, have you?
Not sure I have.
All right. So what's your reaction to 46 cases, 1,500 patients, no evidence of spontaneous movement by the patient?
Well, I mean, this is in, presumably if they're doing the isolated forearm technique properly, they're speaking to the patient frequently. As I said,
well, in 46 cases, it's a variable management of the technique. A lot of times they don't talk, other times they do.
Well, basically the patients are comfortable, so why should they move? But it's like you, if you're lying quietly on the bed and you're just having a quiet snooze, you're not moving. But if I come in and were to say something to you like, Anthony, squeeze my fingers, you'd probably wake up and squeeze my fingers.
Okay. Can you, going back to the case you described about where the trainee, the registrar, is it registrar?
I think it was probably a second year SHO actually.
Where he said the patient was anesthetized, therefore there was no need to add more anesthesia, and he was going to paralyze the patient. That reminds us of the situation with Benabanki's analysis of the intravenous techniques, where they were interpreting it Now, let me start again. I won't use metaphor. But there was a controversy in the early MAA meetings where for a number of years there had been a series of implicit memory tests done by psychologists who were working with anesthesiologists, where eventually you and Michael Wang interpreted the papers as reflecting patients paralyzed and awake with explicit memory, and that it wasn't implicit memory. And when you talk to the psychologist about it, their answer was, well, the anesthesiologist told us their patients were asleep. So can you comment on the culture in anesthesia where experienced anesthesiologists would say something like that?
Well, I think at the first MAA meeting, can't remember the name of the authors now, but they said that the end point for a good general anaesthetic was lack of recall, and I think that was taken as implicit that if the patients had no recall, they must have been unconscious during the actual operation. If they had no explicit recall, they must have been unconscious during the operation. And as I said, then I presented my early studies with isolated forearm technique, showing that with the common anesthetics of that era, 60+% of patients were capable of responding at some stage during surgery. So the most likely reason for all these studies showing what they called subconscious memory was probably because the patients were all awake at some stage during surgery, and really it's not subconscious memory they were having, but they were having some sort of they were having a conscious experience during surgery. You'd have to ask the psychologist what it means if they don't have explicit recall for it afterwards, but they can actually describe it on prompting, because this is what I found: if you actually prompt the patients without giving them ideas of what the correct answer is, you can often pull out the fact that they've actually heard something. You know, did you hear anything? Oh, I heard a radio type voice, for instance, but that's all they can remember, a radio type voice or something of that nature. Or I think somebody said maybe something to move my fingers or something. But when you say, what do you remember? They actually say they don't remember anything. It's only when you start to prompt them in the direction of what you know happened that you begin to pull out some indications that they actually are remembering things.
I think the key issue here was that Benno and his colleagues, his Dutch colleagues, genuinely believed that they were presenting stimuli intraoperatively when the patient's state was one of unconsciousness. And they made that assumption because their anaesthetist told them that these patients were anaesthetised.
Yes. Well, basically they said the patients are anaesthetised, and that means they are unconscious.
Exactly.
Yes.
And what we said was that really you cannot rely on the anaesthetist's point of view. And the reason why we say that is because we can demonstrate evidence that with muscle relaxants, it's very difficult to determine whether or not the patient is conscious. And that certainly for me as a psychologist, I was doubtful, and I remain doubtful, although Jackie Andre has actually disagreed with me on this, that you can present material whilst the patient is truly in a state of unconsciousness, and that there is cognitive processing of that material, and that then you can demonstrate it as a type of implicit memory. So we both thought that it was much more likely that during the course of maybe quite a lengthy operation, throughout which certain words were being presented continuously, that there would have been episodes when the patients would have become light, unbeknown to either anaesthetist or psychologist, such that they were actually hearing these words in a state of consciousness, but subsequently with explicit amnesia.
I know from the studies that you and I have done, when we know the conscious state of the patient or the unconscious state of the patient, that we have never found any evidence for any kind of recall at all when we know the state of consciousness, or the state of unconsciousness, when we've been presenting whatever the message was to the patient. Zero.
Yeah.
Okay, so next, one of our experts was commenting that in their institution there's an increase in the use of robotic surgery, with surgeons demanding deeper levels of neuromuscular blockade. And so my question was, okay, what are the surgeon's justification for, number one, robotic surgery in contrast to the traditional approach, which in turn would justify the increased neuromuscular blockade? And the answer was decreased infections with robotic surgery. What's your view of this development?
I'm not quite sure how they get decreased infection in the robotic surgery, but that would be something for the surgeons to look at. Presumably it's because there are no rubber hands in the abdomen. And I suspect, yes, for robotic surgery they do need deep relaxation. I have seen some studies suggesting that with deep relaxation there's actually less post-operative pain, which makes things a little bit awkward. But even with deep relaxation, you can still use an isolated forearm technique for a considerable proportion of the operation, as long as you're not using mega doses of rocuronium or something like that, which is a relatively long-lasting drug. I think if you're using the shorter acting relaxants and you keep the train of 4 to 1 twitch or something like that or less, I know with 1 twitch you can get a bigger tetanus, and that may well be sufficient. I've never looked at it, but I suspect that may well be sufficient to work the isolated forearm technique. Because I've certainly used the isolated forearm technique when you look at the patient, and basically you just see a tiny movement of the hand, but it is a movement that you have asked for, and if you don't ask for it, you don't get it. So you don't need a lot of muscle power to use the isolated forearm technique.
I think that Bob Vesselis was saying that in his experience what's going on here with robotic surgery is that the surgeons are actually using both arms, and you've got a mummified patient on the table, so there isn't access to either arm. And I said, well, how about a leg? And he said, well, even the legs are all lacking in access, as he put it.
I mean, that's getting into problematical areas if that is a situation where you don't have access to any limb. But in terms of trying to prevent consciousness, I mean, we've just seen Jamie Slay's paper about how good does a monitor have to be to detect awareness, and it's way up beyond the 95th percentile or something like that. And he says even the 95th percentile is conservative. So we don't have a monitor anywhere near that. So the best I could say is that if you're going to be doing that sort of surgery, then I think it's probably essential you use a volatile anesthetic, because I think if you're using 1 MAC or more of inhalation and a volatile anesthetic, you are very unlikely to get even intraoperative awareness, because the one study I've done looking at volatile anesthetic agents, I can't remember offhand how many patients were in it, but there was only 1 patient responded, and that was just after intubation, before the volatile anesthetic had actually started. She was an obese patient, but nobody else responded during surgery that was a very old study. I think it was 66% nitrous oxide, 0.5% halothane set on the vaporizer. We didn't have end-tidal agent monitoring, so I have no idea what the end-tidal agent concentration was. I don't even think we had CO2 monitoring at the time, so it was just tidal volume of 10 mils per kilogram and a rate of 10 breaths per minute. But that's stopped responding during surgery.
Jamie Slay actually said to me that their comparative for that study was the isolated forearm. So I said to him, well, of course the solution is you just use the isolated forearm instead of trying to find another instrument that will match
Yeah.
the reliability and validity of the IFT.
You know, I think people may eventually get somewhere to monitor. I mean, the work that Gerhard Schneider is doing, bringing all sorts of different things into the equation, is really trying to do with a mathematical equation what the anaesthetist is trying to do just on the hoof, as it were.
Yeah.
Bringing everything into the melting pot and making a decision. But you know, perhaps mathematically, a mathematical solution would be better than the one that the anaesthetist is trying to gather together from within his own mind, as it were.